equals 2 minutes on the clock for our first question. Your time starts now. Case 1. Margaret Thompson, a 52-year-old patient, presents to the clinic with newly confirmed hypertension. Her past medical history includes type 2 diabetes mellitus, for which she takes metformin 1 gram daily, and hyperlipidemia managed with simvastatin 20 mg daily. She reports no known allergies. You assess her cardiovascular risk profile and decide to commence her on pharmacotherapy in addition to non-pharmacological management. On examination, her vital signs are as follows: height 165 cm, weight 80 kg, BMI 29.4 kg per metre squared, blood pressure 160/95, heart rate 78, rest rate 16 breaths per minute, and temperature 36.8 degrees Celsius. Question 1.1. What serious adverse effects should be monitored for in a patient starting on perindopril? List 3 serious adverse effects. Alright, time is up and we have lots of potential answers here, but I want you to really focus in on the serious adverse effects qualifier because that does skew marks towards certain aspects of different responses. So the serious things, the things that can have direct serious negative impact on a person's health, are going to be things like hyperkalemia or hyponatremia. They would both kind of be combined into an electrolyte derangement, and I think if you were to specify each of those individually, you would be getting 2 marks for each, given they are both specific to perindopril itself. If you were to just say electrolyte derangement, again, you're kind of losing some of that consultant level finesse that they're looking for. So you would still get a mark, but you wouldn't be getting additional marks from those. If you were to specify decreased renal function or increased serum creatinine, again, that would be worth 2 marks. And angioedema. Unfortunately, well, fortunately not overly common, but unfortunately common enough that it is something you do have to warn patients about, and again would be something that I think would be worth those 2 marks. Now, 2 marks for angioedema because it does have more serious implications to it. If you were just to specify edema or peripheral edema, I don't think you would be getting marks, and I would be saying here that the reason why you wouldn't be getting marks for that one is going to be because we're really trying to focus on serious adverse effects, and just some peripheral edema or edema unspecified probably doesn't qualify in on that serious adverse effects mark. Of course, everyone knows perindopril causes the ACE inhibitor cough, but again, because it's not a serious adverse effect, I don't think you'd be getting any marks from here. We do have some responses in from the chat, so we do have declining renal function, postural hypotension, hyponatremia. Postural hypertension in terms of, yes, causing falls, making it serious. Yeah, I think actually you probably would get that over the line. I guess it's usually not that severe for most patients, and it tends to be more the more old and frail. Having said that, we have specified this patient here does take metformin, has dyslipidemia. We do have a bit of multimorbidity here, so I think given that's the case, yeah, I suspect you probably would actually get some marks there, so well done. All right, we do have other questions for tonight, so let's get another 2 minutes on the clock and your time starts now. Question 1.2. What are 3 non-pharmacological management strategies for hypertension that Margaret could incorporate into her lifestyle? List 3 non-pharmacological management strategies. All right, time is up and let's get to the answers. So if you're ever looking for what are our preventable conditions, what are the things we could be doing for it, RACGP has a whole bunch of resources. We should be using our Red Book Day today, and all of this is ripped essentially directly from there. So do be familiar with it. You will see questions like this come up, and it is an absolute treasure trove of responses. So, of course, we have the DASH diet. Now, of course, in this exam, we are really trying to avoid using abbreviations. So I think it's one of those ones you probably could say DASH diet and get away with it, but if we want to be specific, we should be saying dietary approaches to stop hypertension diet. Thankfully, the name kind of explains what it does. They would also accept the Mediterranean diet. Each of those would be worth 2 marks, but I think you would probably not get 2 marks for each of them, given they're both dietary modification. So tied in that as well, if you do specify dietary modification or calorie restriction, yes, you're going to get a mark, probably not as much as if you were to specify a diet in particular, and you wouldn't be getting marks in addition if you had both of those there. Again, likewise, referral to dietitian for an optimised diet plan, really that's diet control. Given it does show that little bit of more kind of finesse to it, I think you probably would get the 2 marks there, but again, lumped into that same group. Just specifying referral to dietitian, though, without that qualifier, yeah, we all know what it's for, but again, we want to be specific and concise in this exam, so I think 1 mark. An important part of lifestyle modification is things like an exercise plan, so referral to either a physiotherapist or an exercise physiologist, and again specifying for exercise plan. And there is a little trick here which I think a lot of people aren't aware of or keep forgetting. If you have a patient who is diabetic and you refer them to a exercise physiologist, if they believe they would benefit from a group exercise class, they can actually get 8 additional sessions in addition to the EPC referrals to participate in those exercise plans as MBS 8115. So to kind of lump that into a single response, you could say something along the lines of referral for group exercise classes for subsidised exercise sessions under exercise physiologist. Done. Now, also, moderate. If we want to hone in and focus in on what kind of exercise we're talking about, RACGP recommends moderate intensity exercise, 30 minutes per day, at least 5 days per week. We also want to specify some of our targets here, so aim to reduce weight to a healthy BMI, being under 25 kilogram per metre squared, or aim for a waist measurement under 80 centimetres for women. We would recommend dietary salt not exceed 4 gram per day. The exact evidence for that's not fantastic, but it's still one of those things we recommend day to day. We would obviously encourage limiting alcohol intake to 1 or less standard drinks per day for females, and encourage smoking cessation if a smoker. Now, it's not actually specified here about the alcohol intake or smoking, and so you would be able to list those things there to get marks from them. Again, we've got responses in from the chat, so we've got weight loss of 5 to 10%, fantastic, and I think adding in that qualifier of 5 to 10% makes that a really, really good short-term goal. 30 minutes of moderate exercise at least 5 days a week, fantastic, and reduce dietary salt to under 6 gram per day. This is an interesting point because it depends which kind of source you're looking for as to what number will be specified there. RACGP uses 4 grams. I don't think they'd be finicky enough to mark it down for 6, but if you're not 100% sure what RACGP specify, you may be safer not specifying that number there. I know the other one that often gets kind of lumped into that category is in terms of calcium supplementation. If you're uncertain, you're probably better off not specifying a dose, not that we're asked for doses much these days, than putting down the wrong thing and potentially losing a mark from it. So Demi here in the chat has low salt diet, less than 2 gram. Again, numbers will change depending on where you look. Weight loss to BMI 25, fantastic. 30 minutes daily moderate intensity exercise, fantastic. Just be careful using abbreviations. I know you're probably doing it just for the chat here tonight, but I want you to treat these questions as if it's the actual exam. Really write it out as you would in reality, because the more you practice doing it the right way, you're less likely to make a little slip and fall for one of these traps in the exam itself. Fantastic answers though, and doing very well, guys. Of course, more questions. Let's get 2 minutes on the clock and your time starts now. Question 1.3. Margaret returns after a month with improved hypertensive control. Her blood pressure reads 128/82, but she complains of a newly persisting non-productive cough, worse when supine at night and occasionally on exertion. She denies any fevers or nasal congestion and is felt otherwise fine, denies any loss of weight or breathlessness, and states on 2 days she missed her tablets, and the cough seemed to improve. Her oxygen saturations are 99% on room air, and there's no signs of respiratory distress with a rate of 15. What is an appropriate management plan in response to her new cough? Provide 3 management actions. Doses are not required. Alright, time is up. Let's have a look at the answers here. Now, of course, the number one thing we need to do is stop the perindopril. We know this is the ACE inhibitor cough by this description here, and so the first thing we need to acknowledge is, okay, that probably needs to be given the flick. The next thing, of course, we need to do, we're taking out an effective medication in a patient that needs that. We need to be commencing an alternative. You could be looking at something like candesartan, telmisartan. As long as you're putting some kind of appropriate response in there, you're going to be getting 2 marks. Of course, ceasing the perindopril being the most important thing here, 3 marks. The next thing that I know is one of those stupid things you would do in reality, but you often forget to mention these things in the exam, and does count as a management step, but document the adverse drug event in the patient record. That will stop the patient from potentially going through the same response if a year or two or a time you're away, someone sees that patient and says, oh, they should probably be on perindopril, and tries to switch them over, in which case they'll probably have that same thing again. Now, if you ever get stuck, you can always think of symptom management as well. So there are some things that are known to assist with the cough, and even if you're taking away the perindopril, it does often take several weeks to sometimes a couple of months for that cough to fully subside. And so always a good idea to let them know to stay hydrated. They can suck lozenges, or they can have humidified air if they have a home humidifier to help soothe the throat. The evidence for the humidifier is not fantastic, it never really is, but it is one of those old things that still sits in guidelines time and time again, so there you go. Of course, you've done all these things, you've put all these interventions in place. You want to make sure that you're not going to deal with a different issue down the line, or potentially find out that it was actually unrelated to the perindopril, so you'd be organising follow-up in an appropriate time frame. And again, as long as you're specifying something sensible, I think you're going to get marks there. Again, coming in from the chat here, let's have a look. So we've got cease perindopril, fantastic. Commence telmisartan, brilliant. And review in 4 weeks to assess for ongoing cough. Absolutely love it. Swap to irbesartan, add amlodipine, swap to atenolol. Interesting, good. I would be cautious just saying swap, because technically a swap would imply 2 actions. Ceasing one medication and commencing another medication. And so that could be considered overcoding, and they have said previously that they would prefer you specify that you're stopping one medication as one action and starting another medication as its own different thing. Hopefully that makes sense.